Muy buenas tardes y muchas gracias por su asistencia y a presentar esta sesión inaugural que para mí es un honor poder contar con la presencia del profesor Antonio Ceriello. El profesor Antonio Ceriello dará su presentación en inglés, pero entiende y habla el español y me va a permitir que lo presente en español. Como digo, es un gran honor porque todos hemos oído y hemos disfrutado en alguna ocasión de artículos y de presentaciones e incluso de diapositivas que todos recordáis con certeza de sus trabajos y sus líneas de investigación. El profesor Ceriello es el jefe del Research Diabetes Department de Multimédica en Milán, Italia. Ha publicado más de 450 artículos originales y ha sido un líder importante en la IDF y de hecho en 2011, como decía anteriormente, fue el primer firmante de las guías para manejo de la glucemia postprandial y todos ustedes recuerdan seguro esas diapositivas con las olas del pico postprandial y el daño endotelial que todos hemos usado en alguna ocasión. Ha sido presidente en la actualidad del grupo de la ESD para estudio de diabetes y enfermedades cardiovasculares, ha sido uno de los firmantes de las recomendaciones de las guías de 2019 de la Sociedad Europea de Cardiología, que todos ustedes seguro que han leído recientemente, ha sido editor asociado de Diabetes Care, de Diabetes Medicine y desde julio del 2016 es el editor jefe de Diabetes Research and Clinical Practice, que como ustedes saben es la publicación oficial de la IDF. En la actualidad es miembro del equipo editorial de Cardiovascular Diabetology y ha sido reconocido por la Sociedad Europea para el Estudio de la Diabetes con la Camillo Golgi en 2004 y en 2017 con el Helmut Mehner Award de la IDF. Por tanto, es una gran personalidad, un gran experto en diabetes y una persona que nos puede enseñar mucho. Y por eso es un honor, como decía, poder moderarlo y poder presentarlo en este Congreso de la Sociedad Española de Diabetes. El tema que le hemos propuesto es un tema sobre el que él ha trabajado, como no, como gran diabetólogo que es, y es qué nos ha enseñado COVID-19 de interés en diabetes. Seguro que todos ustedes van a tener preguntas que hacer y es por eso que su presentación va a permitir un tiempo posterior para que hagan esas preguntas. Yo les animo a que utilicen el chat para trasladarlas y yo en la medida de lo posible se las haré llegar a él para en los minutos posteriores a su presentación poder debatir sobre este tema que es de gran interés. Sin más, damos paso al profesor Ceriello. Muchas gracias.
Hola, buenas. Soy Antonio Ceriello y después de 10 años ahora de haber trabajado en Barcelona, ahora soy en Italia, que es mi tierra. Y lo siento, pero mi ponencia será en inglés porque lo entiendo, un poco lo hablo en castellano, pero no soy fluente para hacer una ponencia, una buena ponencia. Lo siento, lo siento. My title is to look at what we learn about the management of diabetes during the COVID-19 pandemic. These are my conflict of interest. And for sure, what we have learned that diabetes is a key risk factor for a worse prognosis of COVID-19. This is just a meta-analysis published at the beginning of the pandemic, clearly already showing what I just told you. Diabetes is a very important risk factor for a very bad prognosis in COVID-19. And what I am going to share with you are the following topics. What is the role of the control of hyperglycemia during the COVID-19 disease in diabetes and even non-diabetes, as we see? What about the anti-diabetic drugs? What about the use of antihypertensive drugs like ACE inhibitors and ARBs? About the use of corticosteroids, which is really relevant in diabetes. What about hydroxychloroquine use specifically in diabetes? And finally, the role of thrombosis in the outcome, in the bad outcome of COVID-19, particularly in diabetes. What about the control of hyperglycemia? This is the first paper published on this topic about COVID-19 and hyperglycemia. coming from one that we, unfortunately, now we know very well where is this city in China. And this study clearly shows that in people with having the COVID-19 and with the good blood glucose control, the prognosis was quite good. You see that almost 99% of the people survived, while the incidence of death in people with COVID-19 and poorly control of glycemia was quite high, around 11%. So this was the first evidence suggesting that hyperglycemia can worsen the prognosis during COVID-19. But we have to dissect a little bit this information. First, there is any role of the previous glycemic control during the acute disease? I have to say that the information is quite controversial on this point. This French study, the Coronado study, shows that A1C before the admission to the hospital does not seem to have an important role in conditioning the prognosis. On the contrary, this other study coming from UK shows an opposite evidence. The previous A1C before the admission to the hospital has an important role in affecting the prognosis. So what we know now is that it's unclear. Clearly, my opinion is much better to have a good previous glycemic control anyhow in order to improve the prognosis, but we do not have a clear evidence if the previous glycemic control plays any role in conditioning the prognosis during the hospitalization for COVID-19 in the people with diabetes. But also we learned something very intriguing, that not only high fasting glycemia, but also hypoglycemia, and this is not surprising, of course, but moreover, also the presence of a huge fluctuation of glucose, meaning a huge glucose variability, can influence the prognosis. So it's not only fasting glycemia in worsening the prognosis, but also the risk of hypo combined with high level of glucose variability, conditioning the prognosis in people with COVID-19. Why I say in people with COVID-19? Because we have evidence that the presence of hyperglycemia is worsening the prognosis, not only in people with a previous and well-recognized presence of diabetes, but also in people not having diabetes before the admission for this disease. And you see from the PISA, this study performed in PISA by the group of Professor Del Prato, showing that in particular, the prognosis is affected by hyperglycemia, particularly in people without a previous diabetes. So it seems that the appearance of an acute effect of acute hyperglycemia in people without a previous diabetes is a very bad condition and is really worsening the prognosis of the disease. But is this really new? I think that this information, all this information we got during the pandemic are not new at all. For example, we already knew that the previous glycemic control is not playing an important role, at least as much as playing the acute presence of hyperglycemia in people with diabetes admitted in ICU. So for any reason, but also, for example, for chronic obstructive pulmonary disease, which is also very common in the COVID-19. So in this study, you see that it already was known from years that the previous glycemic control does not affect the prognosis of people admitted to ICU. Not only, but also we know that before the pandemic of COVID-19, that hyperglycemia at admission is a really important risk factor for increasing the hospital stay and worsening the prognosis in people with or without diabetes. This is a study, but we have many other sources, so all confirming this evidence. And also that but this is also true in presence of chronic obstructive pulmonary disease, which means that really this is very bad in this situation. But also, I underlined the possible role of glycemic variability in worsening the prognosis. But this was already known. No, this is, you see here that in people admitted in ICU for sepsis, for any kind of sepsis, the presence or in the first days of high glucose variability was affecting the prognosis. And this was true for people with diabetes or without diabetes. So meaning that the presence of glucose variability is really bad, and we already knew this. Because it's a huge evidence showing that glucose variability is affecting the complication of diabetes, but particularly cardiovascular complications. And we know that in the case of acute COVID-19 disease, the cardiovascular complications are one of the most important complications that TB people are suffering. And I'm sorry, I don't want to appear arrogant. But just at the beginning, because I studied for many years the effect of acute hyperglycemia in diabetes and non-diabetes. Just at the beginning, if you look at the date of when this paper was published, was just the beginning of the pandemic, I was raising the issue that probably we must pay a lot of attention to the blood glucose control in order to improve the prognosis of the people with or without diabetes affected by COVID-19. So the evidence is there. Hyperglycemia, any kind of hyperglycemia, plus hypoglycemia is worsening the prognosis of COVID-19 in diabetes and non-diabetes. But this is not new. In very similar conditions, we already had this evidence. What about the anti-diabetic drugs? At the beginning of this pandemic, several concerns were raised about the use of GLP-1 or SGLT2 and possible beneficial effect of the DPP-4 inhibitors. I have to say that there is no evidence that we have to change the therapy. On the contrary, probably because the GLP-1 receptor agonists and the SGLT2 inhibitors are also showing a benefit in improving the cardiovascular risk profile, probably we have to keep these drugs until there is no clear contraindication in order to improve the prognosis for the disease. What about ACE inhibitors and ARBs? This, you know, this is a very funny story somehow. Sorry to say funny because it was not funny at all. You know that the virus needs as a receptor the ACE receptor, which is the same receptor to which angiotensin is linking. And somebody at the beginning of this pandemic raised the concern, suggesting that patients with cardiac disease, hypertension, or diabetes who are treated with ACE2 inhibitors, increasing ACE2, meaning ACE2 inhibitors and ARBs, which are increasing the ACE2, which is the receptor for the virus, are at high risk for severe COVID-19 infection and therefore should be monitored for ACE2 modulating medication such as ACE inhibitors or ARBs. It was a really panic. Many people, many patients were calling, asking, what can I do with this? Do I have to stop these drugs, which of course they are very important to preserve the quality. They are life-saving drugs because they control hypertension. Until we had several evidence. This is one. This is second. This is the third. That there is no substantial increase of risk for a worse COVID-19. On the contrary, the use of these drugs was somehow associated with an improvement for the prognosis of 19. So, just an hypothesis raised at the beginning of the disease was just an hypothesis, no data supporting this hypothesis, was just a scientific hypothesis. Probably never we will know how much people paid in terms of increased risk for cardiovascular events. What about corticosteroids? Oh, you know that use of corticosteroids is particularly debated in diabetes. Of course, why? Because corticosteroids are increasing glycemia. They produce hyperglycemia. So the risk is that in diabetes, the use of steroids can worsen the situation of glycemia and then maybe the prognosis. But it was really funny, again, that at the beginning of the pandemic, according to some preliminary data, the guidelines were suggesting to avoid the use of corticosteroids during COVID-19. So the recommendation was not only in diabetes, but in any people with COVID-19, the use of corticosteroids is not recommended. Well, now we have a clear evidence that the use of corticosteroids not only is very useful, but is highly recommended, particularly more severe is the disease, more useful is the use of corticosteroids. They save the life. So again, some preliminary data at the beginning were using the idea against the use of steroids, and finally, until we had, but after many months, the evidence that steroids were useful on the contrary. What about hydroxychloroquine? Oh, this is an old story because, hydroxychloroquine has been used against malaria, but also, this is probably less recognized, it has been used in the past also for the management of diabetes. During the COVID-19 pandemic, nothing as the use of hydroxychloroquine has been debated. There were some preliminary evidence coming from China, small trials, suggesting a potential benefit of this compound in the COVID-19 until two publications were showing that they were not useful, or not only, but somehow dangerous. These two papers, one published in the New England Journal of Medicine, the second one in the Lancet, were withdrawn for serious methodological issues revealed after their publication. And you know that today, the benefit of this treatment is still questionable, but even honestly, we do not have so much evidence in favor of the use of hydroxychloroquine. However, during this debate, the use of hydroxychloroquine was still promoted without any evidence by the media and some well-known personalities. Can we now say safely that also Donald Trump was pushing people to use hydroxychloroquine without any evidence. However, in diabetes, hydroxychloroquine is a particular story. It's a particular story because hydroxychloroquine produces a serious side effect, particularly for the heart, which is directly damaging the heart. But in diabetes, it can produce hypoglycemia. If you combine hydroxychloroquine with the standard therapy in a person with diabetes, you dramatically increase the risk for the hypoglycemia. So hydroxychloroquine probably would have been not recommended at all from the beginning in diabetes, or at least the recommendation would have been to use with more very high caution in this kind of situation. Finally, what about thrombosis? This is another story we learn. Now it's clear. Thrombosis is one important cause of death in COVID-19. This is a paper confirming, as many others, this evidence. There is a high risk for thrombosis during COVID-19. and particularly in diabetes. This is a study showing how, if you look at D-dimer, which is a marker of a thrombotic prone status, you see that particularly in diabetes, there is a huge increase of D-dimer underlying an increased risk for thrombosis. And, this was not recognized at all until, why? Because only with autopsy was they were able, the physicians, the pathologists were able to find this evidence that thrombosis was a key factor in leading to the death of the people. But at the beginning, the authorities were against the autopsy, against to perform autopsies in people died for COVID-19, but because probably for the risk of infection, until somebody was not following the recommendation, made these autopsies, finding out the key role of thrombosis. And if you see today all the guidelines about the management of COVID, you see the mandatory use of heparin or an anticoagulant to treat an acute serious situation of COVID-19. So again, at the beginning, the story was different, and over time, we got the evidence against the beginning, what we were believing at the beginning. Why did this happen? I think that we have different causes. For example, one most important that the communication between different specialists has failed. As for example, if you look at the guidelines which were developed during, particularly at the beginning of COVID, even the evidence were starting to accumulate that hyperglycemia can be dangerous. And even as I show you, this evidence was already available. No one guideline coming from non-diabetes world was suggesting to control glycemia. And also, we had the problem that the pure scientific hypotheses were considered equivalent to true evidence without any substantial proof. This is the case of ACE inhibitors and ARBs and of some anti-diabetic drugs. Similarly, the finding of the key pathogenetic role of thrombosis has been discovered that some physicians decided not to respect the interdiction of the health authorities to perform the autopsy or to limit its execution. Some preliminary therapeutic data were interpreted without caution. They may apply to the use of corticosteroids, which were banned for a period of time, and hydroxychloroquine, which has been offering hope for a COVID-19 cure. All the situation was also driven by a global debate in the media, excess information, and much fake news, leading people around the world to be confused and scared. And I believe that you are still there. If you read any newspaper, if you watch any news, it's almost the same. What we are really overwhelmed by a lot of information. Even some are controversial, but at the end, the people are more and more scared and confused. This scenario outlines that facing this new COVID-19 pandemic situation, typical aspect of human behavior prevailed over the scientific consistency with some of the consequences just described. First of all, we do not know, and we never will know, the price people pay stopping, for example, ACE inhibitors or ARBs in terms of increasing the risk for death of cardiovascular events. So what are the possible solutions? I think that we need an effective communication, collaboration, and trust are essential between players involved in the pandemic. But who are the players? I think, unfortunately, anybody's played important role in this unique situation. Humanity never was in this situation. It's the first time that we are so global. Even during the influenza, the Spanish influenza, the situation was different. The connection between the world was not so fast as now it is. And I believe that all professional bodies, mass media, general public, patients, and also people, normal people, need to avoid infodemia, meaning the excess information, and consequently its negative effect. And we need to really share at the different national level and international level what we are learning day by day in the management of this pandemic. So at the end of the day, which lesson is coming from COVID-19 pandemic? We need evidence-based science and decision, because I show you what happened just trusting preliminary data or hypotheses. We need good communication. We need a very strict collaboration between anybody involved in the management of this pandemic, and finally trust. And I believe that this is probably the most important issue at the moment, because I believe that the authorities all around the world were not really facing in the right way and the problem, and people are losing the trust. And this is very important to face a so dramatic situation as COVID-19 was, and unfortunately is, and totally probably will be for a while. Thank you very much. Muchas gracias.
Thank you very much. Muchas gracias, profesor Ceriello, por esta interesante y provocadora presentación. Yo voy a revisar las preguntas, si me lo permiten, y voy a ir trasladándole aquello que nos han preguntado los asistentes. Una primera pregunta me lanza un compañero preguntándome si realmente usted considera que diabetes, obesidad empeora el pronóstico de la enfermedad COVID, o no debería ser, teniendo esto en cuenta, un grupo prioritario para su vacunación, si no sería una estrategia de salud prioritaria, ¿no?
Hablar en castellano y
haré... No problem. If you prefer, you can speak in English.
Haré, if no lo hablaré en inglés. Yo creo que es verdad. La diabetes y la obesidad son un factor de riesgo muy importante no para la infección. No es claro, pero por seguro por la prognosis. La prognosis de la COVID-19 es muy grave, muy grave en las personas con la diabetes y la obesidad. Está claro. Todos los datos los confirman. No es esto, es claro.
Yes, it's true. Probablemente sería uno de los grupos que se deberían considerar como grupos de riesgo y prioritarios, ¿no? En este sentido, profesor Ceriello, un aspecto que ha tocado usted es el control del paciente hospitalizado con COVID y diabetes.
Sí.
Hemos visto muchas dificultades por lo que implica monitorizar la glucemia durante la hospitalización de estos pacientes. El aislamiento, el riesgo para el personal de enfermería, las dificultades de ajustar las dosis de insulina. ¿No tendría un hueco aquí la monitorización continua en hospitalización y no hemos sabido ponerla en valor?
I will prefer now in English because it's more complex the concept. Now we have data about this. There are some papers already published. One key paper published the diabetes care, clearly showing that when you use continuous glucose monitoring and then you get a better glycemic control, avoiding the risk for healthcare professionals, because this is the balance. Because you can also have the monitoring normal way, the testing, but the healthcare physician professionals need to be close to the patient. With the CGM, you can avoid this, and you get really at least two birds with one stone. You can control glycemia, you can improve then the level of glycemia with the optimal therapy. On the other side, you avoid the risk for infection. And this is not surprising. I think that for us working in this field, we were not surprised that the use of CGM can be very helpful this way. But let me really underline that it's astonishing. Until a few months ago, if you go through, I went through PubMed, looking at the guidelines developed by different scientific societies, including the diabetes, those societies, no one was included the optimal glycemic control as a key strategy in the management of COVID. It's really unbelievable. And also, I have to say, when as the ESD study group on diabetes and cardiovascular disease, we approached some colleagues or scientific journals in the emergency, for example, emergency field, they were not so keen or interested on this. So again, I underline what I put in the last slide, we need a really good, very important cooperation between different skills and different specialists. Otherwise, it's going to lose time.
Communication and collaboration. This is a good phrase. Well, another question is about beta cell. Do you think that this SARS-CoV-2 is a focus on beta cell? May be dangerous specifically?
Yes, maybe because of course we already also there are some data in this, but I want to remind that what already happened about the other SARS virus and the MERS. Also, this because this we were lucky that this infection were controlled at the beginning, but we got some data at that time, meaning some years ago. The data have been published. Also, during these infections, there was an increase of new cases of diabetes, but these new cases were lasting for a while. Then people, when they were rescued, they also rescued from the disease, that also rescued from the diabetes. So, for sure, the hypothesis that this virus has some trophies, specific trophies for beta cells, damaging beta cells, so also in this way increasing the risk to produce hyperglycemia. But if you are lucky and you are, let me say, you rescue or you are cured, you have a high chance to not remain diabetes for the life for COVID. This is something that we know from the these two different previous infections. Of course, we will see what will happen about now, because I think that you know that there is a specific registry on this aspect. There is a specific international registry trying to collect all the new cases of diabetes to follow up the long period what will happen in these persons.
Yes. Another question, I think you answered before, but is about the risk of diabetes and hypertension to COVID. Is independent of control or only about bad control, about patient with bad control?
I think that we have to distinguish, because we don't know. Also, I have to say, just 2 days ago, we have published a meta-analysis which seems to show that the previous glycemic control can play a role in producing a high risk for the death. So the data are still controversial. What is the role of a previous glycemic control? My personal opinion is that if somebody gets COVID and has uncontrolled diabetes, uncontrolled blood pressure, uncontrolled dyslipidemia, I don't think that this is a very good situation anymore, anyhow. So, and this also implies that the good strategy for our patient with diabetes is to really reinforce all the effort to keep them in the best control for all the risk factors, not only because this is normal not to do in people with diabetes, even without the risk of COVID, but in the case they get COVID, for sure, they have more chance to survive than they are non-controlled.
Yes, probably with another infection, maybe again the same.
Yeah, yeah.
Right. Yeah, probably the same. And other question is about ECA2, no, the receptor of SARS-CoV-2, and this particularity, no. Do you think this is influence the poor prognosis in diabetic patients? And other question, what is the role of DPP-4 inhibitor in this situation?
This is a very intriguing question. You know, at the beginning, there was so hope for the DPP-4 inhibitors as they can help, but now we got the evidence that there is no difference. There is a few days ago, it has been published the survey from UK showing that there is no difference between the various drugs used for glycemic control in improving the prognosis. My impression is that any data showing that, for example, metformin is very good, because also this was coming out. If you take metformin, you are somehow protected. My personal opinion is that if you take only metformin, this is good because your diabetes is not so bad. So it's not metformin, probably it's the situation which helps you in having a good prognosis. At the end of the day, about the drugs, we have this strong survey from UK with thousands of people showing that there is no difference between the drugs in terms of pro or contra the effect on the outcome of COVID. AC2 receptor, okay, this was a huge question because also, we know that both GLP-1 and SGLT2, they are also increasing AC2 receptor, as well as the ACE inhibitors and ARBs. But at the end of the day, it seems that this is not the key, because the data are really showing that this is not important at all. While probably, my opinion is that in diabetes, in obesity, in hypertension, you have a subchronic inflammation which occurs, is there. And when you stimulate to have more inflammation, because the key factor, the cytokine storms linked to the virus infection, this explodes, superimposing an inflammatory situation to a pre-existing inflammation. And this probably is the key why it's so bad the prognosis. Of course, it's just an hypothesis, because I believe that we are learning, unfortunately, every day something new, including the story of vaccines. No, I want just to raise the issue. We do not have idea about the vaccination in diabetes.
Yes.
Who knows if they are really producing the same good effects, or they are producing more side effects. So this is still an open question. But all the disease is unfortunately an open question.
Yes, yes. And other question is about after COVID-19, no? Is about if you think that diabetes patients after COVID have more complication, more disease.
Yes, this post-COVID syndrome.
No? Yes, if there is a post-COVID syndrome more prevalent in diabetes patients.
Exactly. I think that we still not have data yet, meaning that we know you are starting to know this post-COVID syndrome, which is complicated to understand because also is it's affecting many organs. There are so many different symptoms that is very complicated to understand. But I am not aware of a specific survey in diabetes, which would be very, very important to know, because by definition, if people with diabetes are at high risk, you can suspect that they can have more risk for this post-COVID syndrome.
Perdón que se había perdido esto. Other question is about organization of the assistance to diabetic person. No? Obviously, in this pandemic, we learn a lot of things. One of these is telemedicine. No? What do you think is the role of telemedicine in diabetes?
I have two answers. One is the general answer that this will be the future. We were speaking about telemedicine almost 10 years ago, and was just a curiosity, let me be honest, for experts. It was not reimbursed and blah, blah, blah. So it was now we were pushed to do this. And I'm sure that this will be implemented more and more and more, because also it's not safe only for COVID, but it's cost effective because you do not need people to move, to interface every day. And in the pure Italian and Spanish style, to spend, let's say, 20 minutes when you can spend 10 minutes for a visit, because you are people who really like to chat. This is part of the visit. Sorry, but this is the reality. On the other hand, I worked in Barcelona for many years, so I know very well the Spanish healthcare system. In my opinion, the Spanish healthcare system is one of the more advanced in Europe in this. I am really confident, particularly for Spain, that it will be not very difficult to implement more and more this approach.
Yes, it's true. And come back to diabetic drugs. Other question is about glucosuride drugs and GLP-1 analogs. No? Do you think this is a good option during hospitalization?
First of all, we have clarified, because the one idea was that the SGLT2 can be particularly useful. And there is a trial which will be presented next week at the ADA, but we already know the outcome. It was a neutral. So there is no miracle from this drug in COVID-19. The point is, and we also underline some guidelines that we published at the study group on diabetes and cardiovascular disease and diabetes care, that there is no reason to stop, meaning. But also it depends, of course, you can stop if you see the possibility of side effects, of a contraindication. This is normal. And probably it's a good idea to stop if the person goes to ICU, because this is a different story. If somebody with COVID just is hospitalized, okay, we have to pay attention, we have to start anticoagulants, we have to stop any kind of therapy. The story is different if somebody goes in ICU. I'm still convinced that the best option in ICU is insulin therapy.
Yes.
And there is no doubt about this.
I think the same. There is not enough study about this new group to use in hospitalization patients. No? I think insulin is at the moment the fair option, more when we are talking about diabetic with hyperglycemia, diabetic with corticoid therapy. No?
Exactly. I don't think that particularly whether you need to use the steroids, and this is good. We have evidence that also they work in diabetes. On the other hand, we use steroids only where at the end of the day, when they are very important, that they are saving life. So it's not a case to discuss. But I want to see which kind of therapy you can use instead of insulin to counterbalance the effect of the steroids on hyperglycemia. Honestly, I don't think that we have that much something better.
Yes, it's true. Well, a question that I don't know if do you have the answer. No, it's about the different vaccine to use in diabetes person. There is some study about if better Pfizer, is better Moderna, is better AstraZeneca. What about this different option?
It's so complicated, just the story of vaccines. That now is very difficult. For example, in Italy, 2 days ago, the Ministry of Health decided that AstraZeneca will be not provided for people less than 60.
Yes.
And of course, we have the problem, what to do with who already did the first dose with AstraZeneca. Yes. On the other hand, we have the problem that Pfizer as well Moderna, they are not producing the thrombosis in high, more very clear, but particularly in young people, they increase the risk for myocarditis.
Yes.
Yesterday, it just was coming out the story of SLA, the sclerosis, systemic sclerosis. There is an increase of this side effect, which is, of course, very, very serious. Honestly, it's so complicated. I don't know. And
yes.
to be honest, this, we are, sorry to say this, in my opinion, we are all part of a big global experiment.
It's true. It's true. It's true. But this is a question that diabetic patients do frequently, no?
Yeah.
But it's difficult to answer because we don't have a study to answer this.
No. I was publishing something that probably the background we have is that immunity in diabetes is reduced in terms, and it's the glycemia dependent. There is a huge literature. So probably another issue in diabetes is when is the right moment for vaccination. Let me explain briefly the concept. If you have to make a surgery and you have uncontrolled diabetes, you will wait to have the person well controlled.
Yes, obviously.
If you have somebody with the sepsis, what you do? Okay, you do all the best to control glycemia, not only to control the sepsis, because again, the immune system is highly affected by hyperglycemia. So one issue that we have on the table, probably we need answer, is the case to vaccinate people with diabetes when they are in good control, or is the same when they are not well controlled? The outcome is the same or is different? So we have the big issue, what to do in terms of vaccination diabetes. And then the next is, which is probably the best timing for the vaccination.
Yes. Okay. Well, thank you, Professor Ceriello. There is no more question. Congratulations for your speak. Thank you very much for accepting this invitation to be in this meeting, in this Congress of Sociedad Española de Diabetes. Thank you very much again.
En mi corazón está en España y también tengo una casa en Barcelona.
Muy bien, muy bien. Yo recuerdo una vez que lo invité al hospital donde trabajo, el Hospital La Fe, y realmente es muy agradable compartir unos minutos y debatir sobre estos temas contigo. Permíteme que te tutee contigo.
Okay.
Muchas gracias.
Muchas gracias. Chao.
Chao.